and over to our star speaker, Dr. Vasavada, who's going to talk to us about top pearls for hard cataract phacoemulsification.
Yeah, I just want to comment on the Gaurav. Please listen. I think flex is a very good technology to make incision. Why? Because you can titrate the width of the external incision and separate from internal. What I do is truncated 2.2 millimeter outside, 2.3 millimeter inside. And that I cannot do it manually or any other way. So please, you have the best machine. Please do that. Thank you. Now, I just want to share what I find very useful in dealing with dense and very dense cataract. And preoperative assessment, like all other scenarios, remains of paramount importance. And for me, cataract surgeon, depth of the anterior chamber, space in which I'm going to work, endothelium, and the dilated pupil is the main thing. And then the cataract itself, brunescent, black, postpolar, corticocapsular adhesions, and so on. Very simple. You don't need the OCTs and all the other thing. Would I need pupil expanding devices? How bad is the cornea? Are there guttets? And all this assessment is important in every cataract case, but more so in dense. Anesthesia, I would, from the podium, say, do not hesitate to do peribulbar anesthesia. There is nothing wrong. It's an excellent reassuring technique. I do not do it as a rule, but I would recommend as a general that please consider that. It's very good. Incision is something very important, and as I just alluded, I didn't know that I was going to talk on it, but the trapezoidal is very useful general, and I learned it from Dr. Osher many, many years ago. The descemet detachment occurs more often in the main incision, and that's because your external and internal is like a tunnel, and you manipulate up, down, and all this stuff that produces the detachment. So have an internal opening little wider, as the SICS does that trick when they deliver the nucleus out of the anterior chamber, but only little. So flex or manual, whatever your incision external, 2.2 or 2.4, do a little more internally, so DDs are less and you are free, no locking, no burns. In dense, thermal injury would be seen. So I prefer 2.2, even in a dense cataract. I started with 2.4, but you can with interrupted energy delivery. Capsular axis remains there. I typically do 4.9, but here I want to do a little more, 5.1 generally. And I can do it with like Gaurav and DR with the Lensex, but or the flex. But if you do not have any, you don't need that actually. For dense cataract, you don't need the flex. If you're comfortable, please go ahead, but do a little larger than you would have done otherwise. And always stain with trypan blue, even if the brunescent cataract shows a good glow in a coaxial. You will never know when the pupil constrict, you will not be able to recognize the rexus margin. So always stain the capsular axis. So you can do with the needle or forceps or whatever. But notice, what I did was, I used to do from central puncture in here, but I did on this side also. I made a larger slit, and I'm now pushing this whole capsule in front of that slit away from me, so the both ends of the rexus gives a strong margin. So chances of that going to the periphery are less, and then you continue in your conventional way of, everting and taking your time, and always classical teaching is to go a little bit beyond that starting point, overshoot that. But this is the kind of rexus I'm very comfortable with, the denseness of cataract, quite large, which 0.2 or so more larger than normal. This is a normal rexus, but that's okay. Now, where is it? Next step would be hydro. Now, there are a lot of controversy. Should I do it? Should I not? Because the bag is so much stretched over the years, and if you overdo it, you might rupture intracapsular block. On the other hand, these dense cataract quite often have a capsular cortical adhesion, and if you do not do it and stress the rotation, you might produce a problem. So I don't know, but what I now have settled down is to do a gentle, I want to do hydrodissection, number one, but very gentle, not as forceful as I would do. And if I find that it has gone a little bit at one place, I won't repeat that in another quadrant. And I can always repeat that if I find struggle. And that's because of this corticocapsular adhesions that was described in 2003, more common in the white cataract, dense cataract, younger people, cortical cataract, and so on. So I use this Akahosis modified locally made cannula, which I find useful. Whatever you're using, bend a little bit towards the curvature of the lens, not the classical teaching of cortico-cleaving hydrodissection where you tend the anticapsule up. No. Follow the curvature of the lens, little down. And very gentle hydrodissection. And if I'm happy, you can't see the wave, and don't try to see also. You will never see that. So that's fine. This gives me an impression I'm okay. But it's a feeling, proprioception. If necessary, always be ready to repeat that. But I think it's important to do that. Now, this is the real thing. How are you going to remove this? I think we should have in our mind a clear concept of how the lens is removed. First, creating a space, if you want to believe that. Then division, different parameters for division, and then removal of the divided fragment. So complete the division first, and then go to the removal with different parameters, particularly in this dense cataract, where you want to protect the capsule as well. So creating space is a good idea. You can do it direct chop, but in these bulky cataract, I would recommend strongly, you may spend 3 or 4 millijoules more energy, but it's worth. But you want the depth more than the length of the trench, and you can actually go as deep as you can. Dr. Gimbel described years ago downslope sculpting or whatever, but as deep as you can, but not stressing the subincisional zonules. The Kalman tip and bend tips, 45-degree bevel is the right combination for a dense cataract. Now, next stage, as I said, is the division, division. But notice the parameters. You don't need a vacuum. You just want a vacuum to run the pump. 50 millimeter is enough. Not too much of a flow rate, but sufficient power. All right, so that's having done that. Now, the next one would be the division. And that is really key, and the aim is to have a complete division of the entire anterior posteriorly. Whatever the chop maneuvers you do, direct chop, Nagahara, horizontal step, vertical, do in a step-by-step manner. That's the essence. And when I say step-by-step, same thing whether horizontal or vertical, create a crack. Do not aim total division at one stroke of the chopper or like that. The whole lens tilts in horizontal, and there you can repress. So create a crack, place the chopper into the depth of the crack you created. Once again, repeat the maneuver. So progressively, in a step-by-step manner, take that thing that you created. And notice here that the vacuum will go to the highest. The foot pedal is in third position, and once it occludes completely, you want to come off to the second position. The 3 figure will become 2. Now I have lifted my foot up. So total vacuum achieved, and then initiate the crack. Do not aim a karate chop, one division, and then place the chopper into the depth nearer to the posterior plate, and you can remove the occluded tip and re-block it, as I call multi-level. But whatever, take in a step-by-step manner and not one stroke. And you can have different examples with the different grades of cataract. Whatever maneuver, go in a step-by-step manner. Do not aim one stroke. These cataracts are very dense. They look okay when you see the red glow, but they are really quite leathery and tough. So you go through that, all that. You can do that in a small pupil, I would recommend you to use the pupil retractors or a ring expansion, not this. No ego, but I'm showing you just to prove that this kind of movements is quite safe. It's not a blind procedure. You are able to see everything even through the small pupil, and you can achieve the goal of total division. Continue that 360-degree round and make as many fragments as you can. And once again, the similar thing, loose zonules, high myope, floppy bags, it will work every time. And I don't do this technique every time. I do straight direct chop sometimes, horizontal chop after space. Whatever I find good in that particular area, I would do that. And the same thing, total division, first in 2 halves, and then you start occluding. I learned from Dr. Paul Koch, I mentioned it in the earlier hall, that reduces the stress to the entire back. If your total division in 2 hemisphere, whatever maneuvers you do will be restricted only to that part of the hemisphere and the capsular back. So it's a good idea, before you proceed to a total division in multiple fragments, create 2 distinct separated fragments, zones. And then you do that. This is a direct chop. Straight away, you see the milk coming out with so much of energy in an occluded tip is a waste of energy and loaded. But you can do that. But notice the whole lens tilt, because I am aiming at total division. I don't think you need to do that. But there is nothing wrong if you have a control and go once again progressively deeper in the depth. You may have to have a whatever expansion device you have, but same thing, you can do that, the horizontal chop in this cataract. It is little more effective than what I showed earlier, but the safety margin is little reduced in this technique compared to the one where you go in a chop in situ step by step. But now you can impale this tip once again in the depth and bring the chopper there. You can do in a small pupil like the other one. It depends on how much practice you have in a particular action. Now, posterior plane, as I said, is important. I think we are done through that. And multi-level chop is the same thing. It helps you with minimal stress. Start the division, take both the separating forces, the occluded tip and the chopper, again nearer to the plate that you want to divide, so that you don't have to have a lateral separation movement as much as you would do otherwise. And this illustrates what I'm saying. I'm taking this occluded tip once again and re-occlude it again at the depth, and then I could achieve that crack very well. Once again, similar thing. Now, finally, fragment removal is the one which will decide clarity of the cornea, because if you are in the anterior plane, you would be difficulty. So, first thing is produce as many small fragments as you can, so they are very easily manipulated, and also be aware of the plane which you are removing. You don't have a slit lamp. I don't have any more now, but be conscious the level of the emulsification and try to be as away from the cornea as possible, and therefore you need a low aspiration flow rate so that you don't rupture and threaten the capsule as well. And repeated use of dispersive viscoelastic containing chondroitin sulfate is really very useful and very protective to assure a clear cornea day one. And we had a rule, 1 minute of clock time or 2 minutes depending upon the endothelial health. I would be given a viscoat or a chondroitin sulfate in my hand, and we'll keep injecting every 2 or 3 fragments the viscoelastic there. So I hope it comes here now. But notice the low IOP, low flow rate, and even with this low flow rate, 20, it comes up very well. So this is what I meant. Keep injecting viscoat and continue doing that. Flex, as Gaurav has said very well, whatever you do, you want to have this as an aim. I don't produce this every time, I must say this. but this is one of our good ones that I want to show that clear. But the final pulse is counseling. Tell all the possible eventuality like this one, PCR, and change in plants and so on. Explain to the children as well, and not to the patient itself. But technically speaking, go slow, step by step, aim complete division, multiple fragments, try to remain away from the endothelium, general use, and have a backup plans. And finally, once more, again, to remind you that there is a APS-CRS meeting coming up second time in India after 12 years in Ahmedabad in August. And particularly for juniors and beginners, I would recommend very strongly because it's really a quality teaching by the masters there. Thank you so very much, DR, for the opportunity. Thank you.
Thank you for that excellent exposition. Just one quick question. All you showed was direct chop techniques, varied direct chop techniques. It seemed to work very well in your hands. What about stop and chop? You know, many of the youngsters may be more adept at that, creating a deep division and then cracking into two heminuclei and then subsequently dealing with
that. Is the best. That is the best, and I do that. I just showed the different ways of chopping, but I did, I think, mention, and thank you for bringing it up. I cannot agree more with you. Creating a space is very important in all cataracts, but particularly in this dense cataract. And it will reduce that force and the power and everything. So, yeah, I agree.
In fact, I think you did show one where you had made the trench nicely, you know, quite deep, and then you did the, you know, direct chop. That itself, you know, works really well because you've created space, you've debulked the hardest part of the nucleus, and then you kind of go into it, so it works well.
I think that's the rationale you brought here. I forgot to say it the way you say it, but that's very good. I think my point is, you have your trick, and you have to change your chop techniques every case, or even in the same patient. You start with that, and then you find that I'm not able to go direct under the capsule. Don't worry. Start horizontal or the vertical, and so on. So have many tricks up your sleeve. You can use multi-level. You can do this, that. There are ways of, and everyone has their own tricks, and everything works.
I think the bottom line is to break the backbone of the nucleus.
Posterior plate complete division is the real key.